Great.
Okay.
Thank
Thank you
you.
very much. Thank you very much. I'll share my screen as well again, and I'll say include sound here. We don't have sound though. And present. Right. Okay. So we're just going to talk a bit about child sexual abuse and primary care with a lot of focus on communications. And I'll make a start, and then I'll be joined by my colleague from the ICB, Chitiga Hope, who will talk a lot about the communication bit. So in the next 1 hour, what bear with me, yeah, so in the next 1 hour really we'll just cover the context of child sexual abuse, the legality of sexual activity and age, because this is a question which we are asked a lot of times. What are the indicators for primary care when a child presents? How do we communicate? That is the biggest section here, which Hope will speak about. How can we use our systems, if at all, and just touch very briefly on the MASH advice on how to refer. So I hope that's okay, and then we take some question and answers as well. So do feel free to type your questions there. So again, just before we start, if you do not mind, those of you who are comfortable doing this, if not, it's absolutely fine, as to how confident do you feel in approaching a consultation where child sexual abuse needs to be considered, because it's something which is not a very easy thing to really approach for many of us, and but it's something which we have to do. So it'd be good to know how people feel in general, and really, and my hope is that at the end of the day, people will feel a bit more comfortable in approaching this. Um, some of us might have never approached that situation, but if you were to, how would you feel about it as well? So, okay, just give it a minute more. Okay. So I mean, I think based on the numbers so far, about uh, two-thirds of us would feel not confident or would struggle with this, and just over a third would feel fairly confident, which is good. And not surprisingly, almost nobody is very confident with doing this. And again, that is totally understandable as well. Um, it is a very difficult topic for many people across, not not least for the victim actually who's going through this. Okay, thank you for your answer. That's very helpful there. So I'll just go very quickly about think of this child M, who is a 9-year-old girl and presents with her mother with a second episode of soreness down below, was seen at the practice and treated for thrush 3 months ago. So, and you are a clinician, whether you are a nurse or a GP or an advanced care practitioner. How would you approach this? So feel free to just type it out, your answers there, as to how do you approach this? What are you considering uh, in this case of a girl coming with mother with a second episode of soreness before you will start to see them, or you call them into your room if you know that's what they're coming with. It's a very broad thing. Yeah, okay, yeah, and you can, okay, safeguarding swab, ask about hygiene, yeah, I think this happened. Mash, diagnosis, yeah, careful questioning. And the way this works is the more an answer is given by people, then it gets larger in size. So the ones in green are the most common answers or words. Okay. Yeah. Hmm. Okay. So there's some very good, important answers here. Hygiene, take a swab, think of safeguarding, check, ask about sexual activity, which is the difficult bit because this girl is 6 years old, and to ask about sexual activity is always going to be a challenge. Think of UTI, who lives at home? Yeah, important. Rule out any other cause, medical cause, take a swab, document who's bringing them, who the child has come with, who lives in the house, examine them, check for UTI, any worms, any irritants, how things at school, potentially a MASH referral, a UTI query. Has anyone actually examined the child? Check, yeah, so actually, so very good. So really, a lot to process for any individual who is faced with this, and we're trying to manage this in the time that we have in a safe way, because we might be the only professional that this child has seen who, and if they are being abused, then it could be their only hope really of being picked up. So yeah, so clearly there is a lot to cover here, a lot of ground to cover, and which is why I think sometimes we feel less confident. Do I treat this medically right now? And if I go down safeguarding, how do I approach this question? How do I ask them? What all do I cover? So, okay, thank you very much. I think a lot of our thinking around hygiene, swab, safeguarding, and the home situation as well. So, just to give you a bit of definition, really, so thank you for that. So, a child sexual abuse involves forcing or enticing a child to take part in sexual activities, whether or not the child is aware of what is happening. This includes physical contact, which includes both penetrative and non-penetrative acts, non-contact activities, in today's world of social media, involving the child to look at or produce any pornographic material or watching sexual activities, or to encourage a child to behave in a sexually inappropriate ways. So it's a variety of things which actually do count towards child sexual abuse. So let's just talk about firstly a child at the age of 13. So what about sexual activity in a child below 13? So by law, any child under 13 cannot consent to sexual activity. Therefore, any sexual activity will lead to prosecution potentially, and penetrative activity is actually rape. So if as a clinician we come across a child who we know is sexually active below 13, we have to inform the police and make a MASH referral as well. This is pretty black and white. Of course, you inform them as to what's happening first, but it is our duty to actually inform the police and make a MASH referral. That's pretty black and white. There is no gray here. Then we come to 13 and 15 years olds. What about sexual activity that involves this age group? So it is illegal below 16, but the prosecution is highly unlikely if both are children in that age group, 13 to 15. So there's not a massive age gap. So it's not a 13-year-old with a 16-year-old or something like that. And it was mutually agreed, and there was no evidence of any abuse or exploitation. So this is not an uncommon scenario of youngsters 14, 15 exploring themselves sexually. But there is not much prosecution that we see happening in this age group, and that's only because they're both in a similar age group. So it's not legal, but things do not tend to take a legal route in this case here. Then come 16 to 18-year-old. So in this case, it is legal if the young person has got the capacity to give informed consent. And I mean 17 years and 364 days, and not 18 really. However, sexual activity in this age group with a close family member is still not legal, and that would constitute a familial sexual abuse or incest as spoken here. So these are just some basic rules. Again, just to reiterate that a person consents if they agree by choice and they have the freedom and capacity to make the choice. That's for a child or for adult. Now, in some cases, a young person cannot, sorry, and a young person can never consent to their own abuse, and they might not even recognize that they are being abused. Hence, the the capacity to consent to sexual activity is impaired, and it's more common in the following scenarios: when they've got a significant mental disorder or disability, if they have consumed a significant amount of alcohol and or drugs, or the activity is with an adult in a position of authority or a power. It's very important as well. So, for example, think of like school teachers, etc., uh, or where there is an evidence of child sexual exploitation or coercion as well. Child sexual exploitation is a form of child sexual abuse, and it occurs when an individual or a group of individuals they take advantage of an imbalance of power to coerce, manipulate, or deceive a child or young person under the age of 18 into sexual activity. It's very similar to domestic abuse if you see around the coercion and the manipulation, and they do it in exchange for something the victim needs or wants, and it could be financial advantage or increased status of the perpetrator or facilitator as well. So it is a form of child sexual exploitation is a form of child sexual abuse. So I just show a few more slides which I have based on the Royal College of Pediatrics Purple Book, which outlines the good practice for pediatric examination with a concern about child sexual abuse. And this is like an interpretation for primary care. And they do say that actually a medical examination has limitations in the validation of child sexual abuse, as a high proportion of patients of children who have been sexually abused have no anogenital signs at examination, which means that actually a normal examination alone does not rule out child sexual exploitation. So that's important to note. But the purpose of the examination is also to complete a holistic examination as well, to ensure the child's health and well-being is looked at. You know, that that's why it is important to do the medical examination and not underestimate the value of it. But a normal examination does not mean there is no child sexual abuse going on there. So, in primary care, when do we consider or suspect child sexual abuse? I think it's important just to understand the wording here. Consider means that abuse is a possible explanation for an indicator, but it is one of several possibilities that makes sense. As opposed to suspect, where actually a serious or immediate concern or a likelihood of abuse is there. So you actually believe that abuse is likely here. That's when you suspect it, but we need to consider abuse in a lot of settings as well. So first and the foremost thing is essentially the allegation of sexual assault. So if a child discloses to anyone at any point of time that they have been sexually assaulted, then that has to be taken into account essentially. Of course, many children they do not allege this uh, at an early stage because they are being groomed or being threatened. So it might come down the line after many months or after many years or even decades as well. Now, if the child does allege that it's an acute assault, then you need to act urgently, same day, essentially. Yeah. And the one reason why a child may not make an allegation is that they may be very young or they're pre-verbal as well. So just bear that in mind. Again, where there is if the adult says, if a parent says, or an aunt or uncle or a teacher says that they have concerns about CSA, then we should consider that as well. Any pregnancy in a child below 16. So even though we said that sexual activity in the age group of 14 to 15 is acceptable, if not legal, we still need to consider that what's going on here. So your threshold is much higher there. If you get an STI in a child, that's always your thing. Even if it's a very important part that if you get an STI in a child, and a child means anybody up to the age of 17 years and 364 days, that you consider it. Warts, genital warts, is something when you would definitely consider sexual abuse. Or again, as I said, a, a child over 13 is sexually active or pregnant, then you must also think of child sexual exploitation as well. Any anogenital injury with an absent or unsuitable explanation, any unexplained vaginal bleeding, basically an example an acute bleeding in in the absence of accidental trauma or medical explanation, any unexplained rectal bleeding, child. Now, this is a very common topic that we see, vulvovaginitis and discharge, like the the case I told about with the soreness down below. Now, it's a very common finding in pre-pubertal girls. That's because of a lack of estrogen. There is more dryness, and they can get more episodes of vulvovaginitis. And the main concern would be when, if it is a recurring picture or resistant to the treatment, that will become much more concerns. So when a child does present with a discharge, then I think it's important to take a careful history and a full examination. But if you're considering that actually this is something else going on, then you might need to escalate this. As GPs, we are not geared to be able to do these kinds of examinations. I'll take any questions at the end as well. Then let's talk about behavior as well. So in primary care, we might get children who might actually express their distress in other ways like self-harming, aggression, anxiety, poor school performance, sexualized behavior as well. Abdopain, recurring abdopains, enuresis or headaches. A lot of victims of domestic abuse, they come to a GP practice, as Swati said, multiple times. They might come with abdopains and they might go to A&E. Similarly, a child coming to you with abdopain, which is a very common presentation. And yes, it's something to clearly be aware of. Any change in the behavior? So a sudden change in somebody's behavior is alarming as well. And the one common thing which we might be asked is about masturbation. Now, whilst it is normal for a child to masturbate, it's worrying if it is excessive, which would mean if they're doing it in public or if it is interfering with their life. Again, any child that lives with any adult who poses a risk to the child or is in contact with a sexual offender, we have to bear that in mind with every consultation. If the perpetrator is actually a child, then they too need to be considered as a victim in their own right, and they might need to be referred for a separate child protection investigation as well. So that was just to give you a bit of a context about the picture there. Sorry, wait one second. About the context of it and the legality of it. I'm just trying to stop sharing my screen. Apologies. There. So now I'm going to call in Hope. Hope, are you here with us?
I am. Good afternoon, everybody. I'm Hope Kitiga, and I am Deputy Designated Nurse for Safeguarding Children and Children in Care at the ICB. And I'm here today to talk to you about communicating with children. So I don't know, Raja or Liz, if you can share the slides, please.
I will do that. Yes, I shall do that now. Hope, just one second. Bear with me. I think I got the right slide. Just coming up here. So I share and I'll include sound. Thing here. And now if I go to your presentation, present. Oh, sorry. Apologies. There you go.
Thank you.
Shall I go ahead? Next one?
Yes, please. So just a bit of context. What we know is that professionals often worry about how to start conversations with children, what words they can use, what should be avoided. But this is just reassurance that actually as health professionals, you're already really skilled in holding difficult conversations. And there's so much that those working across all areas of health can do to give children the confidence and opportunity to communicate about child sexual abuse. A lot of research has been conducted, and it actually shows that children want us to ask direct questions about whether they're being sexually abused or not. Next slide, please, Rajat. This is just a short video clip that we're going to play, and it was done by the NSPCC, and it just really highlights that sometimes as professionals or as adults, we actually mirror the same anxieties as children, but the onus should really be on us to talk to children about child sexual abuse.
Let's go all the way down. Keep the ball moving.
Something's happening.
Something's happening.
Something bad.
Something bad. I'm too afraid to say anything.
Too afraid to say anything.
I know I've got to be brave.
I know I've got to be brave.
It's hard.
It's hard. Talk to me.
Talk to me.
Okay.
Let's go all the way down.
So that's basically just illustrating that sometimes as professionals, we are mirroring exactly the same anxieties as children, but again, reinforcing that message that it should be on us as the adults, as the professionals, to talk to children about child sexual abuse. What research has shown is that children face a number of barriers that prevent them from communicating about child sexual abuse to professionals. These barriers include and are not limited to fear, and that can be fear of what will happen if I disclose this, what will happen to the perpetrator or the person causing the harm. It could be a family member, for example, that actually the child loves. It could be their father, a sibling, and they have that fear about what will the consequences be for that perpetrator. The child may not actually know that abuse has taken place. So I want us to think a little bit about our disabled children, our children who are pre-verbal or non-verbal, and of course children who may not have the language, and that may be simply because they don't understand English, they don't speak English, they've recently moved to the country, or they don't know what is happening to them and they don't know how to talk to someone about it. And it may be that they term their private parts different things, like they may say, someone has been touching my flower, for example. And as professionals, we need to have that professional curiosity to be able to delve a little deeper to understand what the child means. Children may also not have the opportunity to disclose. They may feel a lot of shame about what is happening to them. They may feel guilt as well and fear that actually I am responsible for what is happening to me, or I'm responsible for my siblings. If I say this is happening to me, what's going to happen to my siblings, etc.
Next
slide, please. Yes, please. Additional barriers can include a child's sexuality. What we know from research is that male victims of child sexual abuse are predominantly abused by men. So this is just an example. For example, if a child is heterosexual, it's even more daunting for them to disclose that they have been abused by a male. So we just really need to consider children's sexuality as well, and how this may be a barrier to disclosure. Ethnicity is a really important one. So we need to consider a child's ethnicity, their religious and cultural beliefs, and how this may impact on disclosure. So, for example, if someone is from a culture where there's shame, it's about honor, it's about being able to get married when you get older, they may disclose to a close relative who in turn tells them not to disclose to any professionals. So the abuse may stop, but that child is unlikely to go ahead and disclose to other professionals. If we think about ethnicity, perhaps racism, and how that impacts safeguarding children, children from Black and minority ethnic backgrounds may struggle with disclosure as well. And we know that children from these backgrounds are more likely to be adultified, so treated as adults, and this may actually stop them feeling able to talk about what is happening to them. Another barrier, of course, is the child's relationship with the abuser. And sometimes, for example, if it's intrafamilial child sexual abuse, that can be a really complicated relationship. It could be that child's grandparent, it could be a sibling, could be a parent. And it may mean that the child has these complicated feelings about that abuser. They may love them. They may think what is happening to them is because they're special. So that's another additional barrier where the child will hold on to that and keep it as a secret. And then lastly, just thinking about disability and special educational needs. These children are more likely to be in residential care, and we know that that raises their risk to child sexual abuse. They're also more likely to have any symptoms of child sexual abuse explained off by professionals as perhaps a result of their disability, of having to have intimate care, for example, or because of their behavioral challenges that they've scratched themselves or they've done this to themselves. Next slide, please, Rajab. So now I come on to a bit about talking to children. So if a child is to tell someone about their abuse, they need to choose who they will tell. And the likelihood of them telling a particular person will depend on if they feel that that person will believe them, whether they have a trusting and reliable relationship with that person. It'll also depend on that person's body language and how the child feels the information will be received. And of course, it depends on the opportunity as well. So if you're a professional and you have the opportunity to talk to a child, just to reiterate that children want you to ask direct questions and the onus should be on you to ask. It is always advised that you comment rather than interpret. So, for example, I notice you crying, or open the door. I am here if you want to talk about something that's troubling you. Be very aware of your own body language. Research and talking to survivors has always indicated that sometimes children start to make a disclosure, and because the person they're disclosing to appears horrified or taken aback, they then retract on that disclosure. It's also really important to give the child time. Sometimes it's so hard for them to just make the full disclosure in one sitting. So, for example, you could say, if you're a GP, perhaps you can come and see me again next week and we can talk a bit more about this if you would like to. So really giving that child time and the option to come back. Of course, you've always got your safeguarding hat on. And if you think there's risk of significant harm and a MASH referral needs to be made, then of course you're not going to give that child time, but you're going to take the necessary safeguarding action. You can also use resources. So for example, older children, perhaps you can show them an online resource and just ask them to work their way through that. You can give them an alternative. So suggest like a best friend question or third person example and talk about that. For example, if you had a friend who is experiencing something difficult, what do you think would stop them telling, or what would help them? Or if your best friend was going through something hard, what would help them to be able to tell a trusted adult about what was going on? So that's really helpful approach when you're talking to children. Next slide, please. And something that can't be reiterated enough is that it's so important to let children know it's not their fault, whatever it is that has happened to them, and also to let them know what will happen if they do go ahead and tell you. So this is a really poignant quote from a survivor of child sexual abuse, and it is that the only grown-up that spoke to me about what would happen if I spoke about my abuse was the person who was abusing me. So research shows time and time again the only adult speaking to that child is the person who's actually causing the harm to the child. So their belief about what will happen next is what the perpetrator of that abuse has been telling them. Next slide, please. It's also really helpful to take a graduated approach. You can keep clicking, Raja. So for example, start by saying, I've noticed you don't seem yourself at the moment. If you know the child well, they've been coming to your surgery for a long time, that's a way to open the conversation. Or I have noticed you shouting a lot at the moment, or I have noticed you look really nervous in this appointment, or I have noticed you're very quiet. And then you would go on to perhaps that next step, which is help me understand what is happening to you. Help me understand why you are more upset. Help me understand why you're really struggling to eat, whatever it is the situation, or help me understand what is causing you to cut yourself, whatever it is that the child has presented with. Can you tell me more about that? I have noticed this and would like to understand a bit more about it. And then the final step is just saying to the child some reassurance. Sometimes we worry about what may happen if we tell someone what's going on. For example, that we may get into trouble, etc. Can you tell me what you are worried may happen if you tell someone what is going on? Or sometimes things happen that young people find really difficult to talk about. How can I help you to talk about it today? So really just empowering the child through this graduated approach to be able to discuss what is happening to them and to make that disclosure. Next slide, please. It's also important, of course, sometimes to ask specific questions to ensure the young person's safety. So these questions are typically who, what, where, and when. And it may be questions like who will be at home when you go home later? What else happened? Can you tell me where they touched you? Can you tell me when that last happened? If the child has told you they've been hurt by someone but haven't given you enough detail, it's important to use professional curiosity and really ask that child, can you tell me who that is? So really ask the specific questions so you get the specific answers, which in turn will also help you if you're referring on or calling the police. Next slide, please. And I think this is really, really important points to remember, that children rarely give fictitious accounts about having been abused, and false allegations have been found to be rare. And actually, sometimes children don't give a consistent account. However, the fact that they've been sexually abused remains real. So it's important as adults that we don't think just because a child's account has differed every time they've told a different professional, it can't be true that it did happen to them. It probably is true, but because of the trauma, they aren't able to give you that consistent account. And the other thing to remember is that the stigma of sexual abuse and trauma of disclosure should never be underestimated. And the damage caused to children when they are not believed is immeasurable. So again, it's just thinking about how we actually talk to children, our tone, our body language, how we respond when they make disclosures, and just holding in mind that they rarely lie. If they say they've been abused, it most probably is true. Next slide, please. So now just some resources to use in practice. Many of you may be aware, some may not, that there is a Centre of Expertise on Child Sexual Abuse, and a lot of the training that we deliver is based on their training. It was formed by the government to look into child sexual abuse, and they're hosted by Bernardo's, but they're multi-agency professionals. So if you have the time, I would look on their website, lots of free training on there. For example, things like communicating with children or sibling sexual abuse. So lots of resources. But one of the resources that they have that can actually be used in practice is the Communicating with Children resource. And they also have another one because we know children, sometimes they have signs and indicators that they're being abused, but find it really difficult to make the disclosure. So there's also a signs and indicators of child sexual abuse guide, which you can use to inform supervision, to talk about in GPMDTs, or to inform your MASH referrals as well. So where you haven't got a verbal disclosure, but there's signs and indicators, it just gives professionals that shared language. Next slide, please.
Our Communicating with Children resource aims to help people who work with children talk to them when they have concerns of child sexual abuse. It is our job to notice the potential signs of abuse and ask about them. There are many things we can and should do to safeguard and support children, even if the child has not verbally disclosed. Our Communicating with Children resource covers why it is difficult for children who have been sexually abused to tell of their abuse, the actions and questions you can ask that may encourage children to tell you about their abuse, and advice on communicating with children in different contexts. Initial conversations with a child about sexual abuse can feel like a challenge. You need to put the child at ease and demonstrate that you are worthy of their trust, while at the same time asking appropriate questions, being attentive to their behaviour, and keeping an accurate record. The resource guides you through your preparation and discussions with the child and their parents or carers. Please remember, child sexual abuse can feel difficult and complex, but by all working together, we can tackle this. Do download the resource and see how it could help in your role.
And that's a signs and indicator template as well, which is available on the website. Thank you.
Perfect. Perfect. Thank you for that, Hope. Thank you very much.
problem.
Very helpful. I just thought I will just talk maybe a bit more about yeah, a few more things, and then we can go on there. So again, so I think essentially the main thing is that each piece of
Rajat,
info. Oh yeah.
Rajat, sorry to interrupt. There's a question saying children, and maybe for Hope as well, or has Hope left? Children are always brought to the GP surgery by a parent. How can these questions be asked safely if the parent is potentially the abuser?
Do you want me
Yes.
to take that,
Yeah.
Raja?
Yes, Hope, please.
Yeah. So I think if potentially you have a suspicion that the parent is the abuser, then I would say that we need to share information. Who would have opportunity to talk to that child? Is that child in an educational setting? So could you speak to school to be professionally curious? Could you ring the MASH consultation line and say, I have seen these signs and indicators, but mum is always present, and they will talk to you about whether it meets threshold for a referral or what the next steps should be. But if you have no suspicion that a parent is the abuser, then we should all be confident as we ask the domestic abuse question. If you are concerned, if signs and symptoms are there, that we ask the child the direct question.
Yeah, I mean, it is very difficult indeed, and that's what makes it hard for us to ask the question. But I think it's important that it is our duty to navigate that. And sometimes it's not just in one consultation, Hope. Would you agree? It might take, unless there is an immediate risk with the child can be brought back, or you say speak with school, and then build up a better picture.
And just lastly, I wanted to add something around the language that we use. For example, we've got a CSPR where language used was asking a 12-year-old if they were sexually active. So as the professionals as well, it is normalizing the conversation. So we can say to mum, we just need to check it's how we ask the question and the language that we use and how we reassure the parent, as long as you don't think they are the perpetrator of the abuse, that this is normal practice and we need to be asking that question, and just use that language that perhaps isn't victim blaming to the child. Thank you.
Thank you, Hope. Hope will be there just to take any more questions as well in a short bit. There's actually one more question for you, Hope. Can I ask, what if there is an immediate risk to the child? How do we ensure that the child is safe when leaving the practice?
If
Sorry,
if
yeah,
there's
go on.
Yeah, if there is an immediate risk and you feel that child cannot leave the practice, then we need to involve the police. And then, as well as the police, we need to be making a MASH referral where they'll convene a strategy discussion and police protect that child from the practice.
Yeah, that's right. I mean, so Harriet, I would treat this very similar to, say, an infant with a bruise who you are suspecting is a victim of NAI that's come with the parent, and you might not want them to go home with the parent because you do not know who the perpetrator is. So in that case, you would call up MASH and speak with them while the parent waits outside, and then you would arrange a safe transfer to either the hospital or for a child protection medical in linkage with MASH.
Yeah. The
Essentially, yeah.
general rule of thumb for any safeguarding is immediate risk. It is the police and MASH for
Yeah.
children specifically, but police for general. If domestic abuse, you're suspecting an immediate risk to the person, please call the police because you need to protect the person.
Yeah.
Yeah, but yeah, very good questions. Yeah, very questions. Okay, I'll share a bit more and then we can come back again. So present. So as mentioned, that essentially it's never the one bit of information. It's very important to match your physical findings and look for other clues in the history, in the context, as people mentioned, who is in the house, what's going on, child behavior, the demeanor, and as Hope said, just hear what the child is saying through their words or their behavior as well. Essentially, think of all the clues. Um, Looking at now, there is actually a very good guidance from the Royal College of GP. They have a safeguarding toolkit, and they've got some of this information as well as to how to identify abuse and neglect in general practice. So we would recommend that you all do. It's free to use. There is no password to go on the website, and it's got a lot of good information as well. And of course, systems. So we all, I think, most of us in the county use Ardens, whether we are on EMIS Web or System One, and there is an Ardens template there which you can use. And by using the template, it brings together all the information in front of you, but also it helps you. There's some links as well about various things which we can use a lot. So what are the then challenges for us? From my point of view, as GP, what I would say is training is a big challenge because we feel that we do not know enough. So we are hoping that this session will be the start of some training for people, but by all means do source more training as per your needs as well. But I think a lack of training does handicap us a lot. Time, we are time pressured sometimes, we might have 15 minutes or so, but remember, this could be life changing for the child and the family. So always ask somebody else in your team to perhaps see your next patient because you might be stuck for next half an hour, just to explore these things. So it's very important to have a supportive environment in your practice to actually be able to do this work. But that time spent is really worth it because you can make a difference to the child. It's a very gray area at times, not knowing what's going on here, and that's what we sometimes struggle with. Unlike a 2 week wait guidance where there are very clear markers as to what is a 2 week wait criteria, there are very few 2 week wait criteria for safeguarding. So and when it's gray, then it does take time and that makes us uncomfortable, but it's important to speak to your safeguarding lead, who in turn can come and speak with us, and we can speak with other people if we are unsure as named GPs as well. But I do appreciate that it's a very gray area for people. Also, there is now a challenge with online triage. Many practices now, patients access information through triage and not via phone. And in the past, our staff on the phones were very good to pick up some cues, like a shouting in the background or a distressed voice by a patient, or a child crying and not being stopped. So I think with online triage, that does go missing at times. So it's a challenge. Remote consulting as well. We have since COVID, we are doing a lot more remote consulting than we used to do pre-COVID. Just like schooling as well, there is a lot more remote schooling as well, and it does present a challenge because we are not exposed to the patient as much, and also it does require a multi-agency approach. No one agency, whether it be social services or GPs or the police or a pediatrician or a gynecologist, can actually manage child sexual abuse on their own. So it's important to work together as a team to get this right. Um, I just thought I'll show very quickly again system one as to a few people as to where you can find these templates in case people do not know, and then we'll open up to questions as well. So system one, I'm sharing my screen. Can people see my screen still? I hope. Is that right?
Yes, we can,
Yeah, so
Raja.
thank you. Yeah. So there are templates on Ardens for child safeguarding, adult safeguarding, and domestic abuse. So if you click on these templates, there are sections to find about various things, various risk factors in a family household, which might increase your threshold. There is information around child sexual abuse, what scoring to use, depending on the child's age. Are they from 0 to 5? Then you ask certain questions. If they're from 5 to 9, certain questions to ask, 9 to 13, and then the older child as well. So there are good things to help you ask this question. If you're concerned about FGM, which we aren't covering today, but there are some tools there to assess for FGM as well. It's got things various, again, some more indicators as well, and you can make your notes. And at the end, there is something called resources, and there's this website called Brook, which has got a nice traffic light system on the behavior which I spoke about. And what they have got here are so what's so when they talk about sexual behaviors, they have tried to make it a bit easier for us to understand. They're either green, orange, or red by the age group, and they identify whether behaviors such as kissing, touching genitals, masturbating, lifting a child's skirt, drawing art are a cause of concern and what you can do. And they have some green bits, things which are appropriate for that age. Some play, it might be okay. Things which are a bit orange concern when it's persistent, the duration of it, the age of it, the health risk, and a child's behavior, and things which actually are red, which are basically again very, very important to know about. So if you are in doubt, these are quite helpful to use as well. And lastly, uh, a MASH, they have got a document called Right Help at Right Time, which got updated last year. And in that, they do have a section on when to refer. So there are 4 columns. The first column is when everything is fine and hunky-dory, and then the last column is where it would be a MASH referral, and the one in between are more of the gray areas. And if it, while talking on the topic of sexual abuse, what you will see here, they have got the red criteria here. Sexualized behavior, which are highly indicative of sexual abuse, would be a MASH referral. A disclosure of sexual abuse, sexual activity under 13. Sexualized behavior which is not in development for the milestone, it might not be MASH, but you might need to take a look at other indicators as well. So yeah, I think I can stop sharing now. So I would like to sign up by saying that it is not a child's responsibility to safeguard themselves. It is our responsibilities among all other professionals to do that. And whilst it's hard, it's very important that we do try and do it right. Thank you for that. Shall we take any questions from anybody else?
There are no other questions I can see on the chat.
I think they've all been answered.
That's good.
Gone
That's
very
good.
silent.
That's fine.
Thank you so much for coming today. I know it's they're quite difficult slides, but thank you so much. It's very welcomed. I can see that from the chat now. People are saying thank you. We have recorded the session, but of course, if there's anything else that you can share afterwards, we can